Thank you. Good morning. So I'm sure you've all heard the joke, you don't want to know how your sausage is made, and that's applied to a lot of different domains, including passing laws. But up till now, what you have heard is how the sausage has been made in terms of how we arrived at a process to determine whether caffeine has adverse effects. And the next presentations will go through those individual outcomes that were evaluated in aggregate. This is a disclosure both for Dr. O'Brien and for me, and we don't have any conflicts of interest. The next slide you've already seen before. It's the comparator slide, and that reminds us that what doses we're looking at in terms of adverse effects, either below or above those effects. For the behavioral data, in fact, the focus and the research that's out there is pretty much only on healthy adults. Their comparator is 400 milligrams of caffeine, and keep in mind that 400 milligrams of caffeine would be roughly 3 or 4 cups of coffee, and average American intake of caffeine is roughly 170 milligrams per day. So our comparator is well above what most Americans are actually consuming. So the data that were used to arrive at the behavioral conclusions come from a total of 81 studies. What came up in the literature search were many more studies. In fact, while 81 were included, 123 were excluded. The excluded studies typically did not present a caffeine dose, so it was impossible to use the information from those studies in this kind of a review. Most were randomized controlled trials. There were some cross-sectional and cohort study, and only one case control study. We looked at all the populations that we had hoped to study, adults, adolescents, and children. There was minimal data on adolescents and children, as I've already said, and there was no data on pregnant women. And remember, I'm just talking about behavior, not all the endpoints. Exposure was typically, since these were controlled trials from a pure form of caffeine, although there were some studies where specific amounts of coffee or other caffeine-containing beverages were administered, and we could arrive at a caffeine dose. I'm going to go through the endpoints individually next, so you'll see what areas were considered for the possibility of an adverse consequence of caffeine consumption. For all the groups, adults and children and adolescents, we looked at increased anxiety, increased anger, increased confusion, and increased depression as possible adverse outcomes. We also looked at headache, both for all the groups of interest, and we had other endpoints as well. So we looked at sleep as an endpoint. We broke sleep down into 2 categories, which we're calling subjective and objective. The subjective category would be self-reported mood states. So do you feel increased fatigue or increased drowsiness as the consequence of taking caffeine? The objective category would be effects on sleep itself, and that would be typically measured with polysomnography, which is mostly based on in the EEG measure, and also you can measure sleep using wrist activity monitors. As I've said, we did that for all potential groups. Another area that we looked at was problematic and risk-taking behavior, and that would include factors such as substance abuse, smoking, disorderly behavior, and risk-taking. I want to, before going into the results, I want to point out an issue that we considered as we did the review, and that is that caffeine is frequently consumed for its behavioral effects. So individuals would take caffeine to have an effect on their alertness and decrease their sleepiness, and in some instances prevent them from going to sleep. And the EFSA, the European Food Safety Authority, has in fact concluded, based on a review of the literature, that caffeine does increase alertness and attention in doses of at least 75 milligrams in the general adult population. So as I said, there were 81 studies considered altogether. Only 5 of those were on children and adolescents. Only 6 were dose-response studies, and only 19 used doses above the comparator, that is above 400 milligrams. Most of those studies were not conducted for evaluating adverse events, but they had measures, or the measures that they used were considered for the purposes of this review adverse events. Many of the studies were in fact conducted to test behavioral hypotheses such as, does caffeine in moderate doses increase alertness, and does caffeine given before bedtime interfere with sleep? So remember that the science is not done from the point of view, much of the science is not done from the point of view of trying to understand whether there's an adverse effect or not. It's an attempt to understand how caffeine, when it's used in doses people normally consume, how it affects their behavior. So getting into the results, for anxiety, one of the mood states that was evaluated, the findings were fairly variable, with about half of the ones below the comparator finding there were some negative effects interpreted in this case as an increase in anxiety. And the overall conclusion for anxiety was that caffeine, both above and below the comparator dose, can produce some small increases in anxiety. And of course, those effects are very much dose dependent. And it was suggested that future research should actually, when possible, use dose response studies as opposed to single doses. For anger and confusion, there were no adverse effects either above or below the comparator. For depression, again, no negative effects either at, above, or below the comparator. And as I said, we unfortunately don't have any data or sufficient data on mood state for children and adolescents to draw any definitive conclusions. So for headache in adults, this is a difficult and complex area. Some studies we know from the literature suggests that caffeine withdrawal can sometimes cause a headache. And in addition, we know that caffeine administration during withdrawal can alleviate headaches. So you have to take that into consideration when you evaluate the data and you think about this issue. Based on 15 studies, it was concluded that caffeine in doses below the comparator, 400 milligrams, are not associated with headache. Sleep. So remember I said that there's 2 separate domains that we're talking about here, the subjective domain, which is self-reported mood state, and the objective domain, which measures sleep by EEG or wrist monitor type measurement. For subjective effects on moods like alertness and fatigue. There was no evidence of adverse effects below the comparator, but at very high doses, in this case 1,200 milligrams per day, there was an increase in fatigue due to disruption of sleep. 1,200 milligrams per day is roughly 12 cups of coffee. With regard to objective measures of sleep, we concluded that caffeine administration, both above and below the comparator, could potentially disrupt sleep, depending very much on when the caffeine was consumed and how much was consumed. For children and adolescents, insufficient data, unfortunately, and with regard to both problematic and risk-taking behavior, that's things like substance abuse, there were insufficient data for adults and children. Danielle showed you this heat map to try and explain that we graded the quality of the evidence, and this is just a small part of the studies that were graded for behavior. And the take-home from this is that you see a lot of green and not much red. So that means the quality of evidence for the ones that are displayed and the rest of the behavioral studies was actually pretty good in terms of the quality of the individual studies. So this brings us to the bottom line. For adults, in terms of all the weight of the evidence, thinking about level of adversity, so not just whether there was an effect or not, but whether it was an important, meaningful effect. 400 milligrams per day was found to be an acceptable intake that is not associated with significant concern regarding behavioral effects. Some adverse effects were noted, in particular with regard to anxiety and sleep below the comparator, and as I said, they depend on dose, time of administration, history of caffeine intake, and also the genetics of the individual. The conclusion was that there's a moderate to high level of confidence in this body of evidence to support this conclusion. This is a heat map for the anxiety data, and obviously you're not going to be able to integrate all this information, but all the studies are lined up here, and the doses of caffeine are down here. And you can see that most of the studies on anxiety are actually done in the doses that Americans typically consume in the 200 or 100 milligram dose range. And you can see the results are mixed. Blue meaning no adverse effect, yellow meaning an adverse effect. For sleep in adults, you can see this difference between the subjective and the objective results. So for the subjective mood measures, we see actually beneficial effects. People say they're less drowsy and less fatigued when they consume caffeine in typical dose ranges, and there's very little information above the comparator. For sleep measured with physiologic monitoring, we see a number of studies where adverse effects, that is, difficulty in falling asleep or disrupted sleep being present. This is the heat map for behavior in children and adolescents, and you see there are just very few studies altogether. The few that are out there did not suggest there was a problem. So I'm going to turn it over to Dr. O'Brien now, and thank you very much.
So now that Dr. Lieberman has given you a comprehensive overview of some of the behavioral endpoints, it's my job to pick out a few of them that you might find particularly interesting based on the questions that journalists have asked me, patients have asked me, and controversies that have come up because I was the chairperson of the American Psychiatric Association review of the diagnosis of mental illness, and in particular substance use disorder. So there are always controversies where diagnosis is concerned, but I'll begin with the issue of caffeine as a reinforcer. A reinforcer to a behavioral scientist is something that causes it to be self-administered. So an animal is self-enforced by drugs like cocaine or heroin or alcohol. They will take it on their own. The same, of course, is true of humans, drugs that are reinforcers. So one of the issues about caffeine is that, just like all reinforcers, it has genetic subtypes, and so some people are very sensitive to the reinforcing effects of caffeine, and other people are not. Some people are able to detect as little as 60 milligrams of caffeine, whereas most people couldn't separate that from placebo. However, when you give someone a reinforcer, and it turns out that caffeine is widely used in over-the-counter medications, and one of the controversies is that you don't know for sure whether or not it's being put in there to make people buy it, because people like the medication more when you add caffeine to it, so that's because it's a reinforcer. On the other hand, caffeine is also an adjuvant, meaning that it increases the analgesic efficacy of something like an over-the-counter non-steroidal or ibuprofen or aspirin or something like that. So this is a controversial area, but it does help, possibly for more than one reason, to have caffeine added to an over-the-counter medication. Another area that comes up is to whether or not caffeine is like an addicting drug. And there is some evidence that people who are cocaine addicts and are given caffeine, they report that they, under double-blind conditions, that they report an effect to caffeine, which is similar to the effect that they feel to cocaine. So, on the other hand, this brings up the very controversial area about children, because we give a lot of caffeine to children, and the question is this caffeine being given to children increasing their likelihood of becoming substance abusers? When I review the literature on that, I don't think that's the case, but other people disagree with me on that. There is also the question of caffeine addiction itself. Now, we did a study of 15,000 patients once about trying to answer this question. And if you ask all these people, are they addicted to caffeine, 100% of them say, yes, I'm addicted to caffeine. If I don't get my caffeine, I go into withdrawal. And they're very positive about that. But it turns out when you do a double-blind study, many of them, and the double-blind means you distract them. See, if you look in the literature, some of the studies don't really do a true double-blind. So the patient knows what you're after. A really good double-blind study has to have some kind of a distractor in it. I don't have time to go into the details of how these studies are done, but the fact is that if you do a really good double-blind study, you find that a lot of people who think they're addicted to caffeine, in fact, when they don't know that you've withdrawn their caffeine because you've substituted decaffeinated beverages, that in fact, they don't know that they've just been taken off. Others, you have to take it down gradually, the way you detoxify someone from heroin or alcohol. So we know from the work that we've done with deciding whether there's a diagnosis, and the APA, the American Psychiatric Association, has decided that The only drug use disorder for caffeine is caffeine dependence. Now, caffeine dependence does not mean caffeine addiction. Physical dependence on caffeine has the best evidence there is. In other words, it's very clear, and Dr. Lieberman just talked about the headache, and this often is confused when people have surgery. Headache and nausea might really be caffeine withdrawal when they had nothing after midnight and they didn't get their usual coffee. So, but what we know is that when you do all the proper controls, people become quickly tolerant to caffeine, which means that doses that they were initially sensitive to, then after repeated use, they become tolerant to it. But if you then stop it suddenly, they do go into withdrawal. The withdrawal syndrome is very characteristic. It involves headache and nausea and among other things, and also a desire for caffeine. But that's not addiction. That's physical dependence. Addiction would be drug-seeking behavior. So it would be people who can't stop the medication or go after it even when they shouldn't, and the way someone goes after cigarettes or cocaine or alcohol, they can't control the seeking of the drug. That's addiction. A lot of people are very confused about dependence and addiction, and if you're ever interested, you know, there's a big literature on this, but the fact is that there is no question but that we have caffeine physical dependence. That's now in the official list of psychiatric disorders. It's not necessarily psychiatric, but it's a physical pharmacological disorder. However, we would all become physically dependent on any drug that we become tolerant to, and then if it's abruptly stopped, we go into withdrawal. It's a rebound effect. In any event, these are just some of the issues. I mean, caffeine is clearly the most widely used psychoactive drug in the world. Everywhere it's used, and it's generally a mild drug. People are always looking for toxicity for it, but the fact is that it's relatively non-toxic, in my opinion, and based on my review of the data. But it does have these behavioral effects that you have to be aware of. I'll end by telling you something that's very practical that you may already have heard about. And the fact is that the National Academy of Medicine, which occupies the big building on Constitution Avenue in Washington, has a lot of meetings there. You heard a report of one or two of the meetings already. The Institute of Medicine, now known as the National Academy of Medicine, meets there. And when you have a meeting of several days with scientists, they usually end with a dinner. Well, the dinner, the kitchen at the National Academy has been given the instruction never to serve caffeine after 6 p.m. And the obvious reason for that is that these poor old scientists will never be able to sleep very well if they start drinking coffee with dinner. So if you ask for coffee, they won't give it to you until the next morning for breakfast. But anyway, so this is a well-known thing. I mean, caffeine has very potent behavioral effects, but by and large, they're mild and not toxic. Thank you very much.